There are only two COPD diseases now. Asthma used to be the third. Asthma is now technically an allergic disorder, but symptoms still resemble that of COPD. In fact, treatment for asthma shares the same treatment as COPD. Okay. So when you have COPD, we can have one of two, or most people, especially the smokers, have both kinds. We have emphysema and we have chronic bronchitis. Acute bronchitis is not COPD because you recover from acute bronchitis. Chronic bronchitis, however, you do not. So both disorders, emphysema, and we'll look at the differences shortly, uh, are characterized by by the name COPD. There's obstruction in the airway. The obstruction can be in the upper as well as in the lower airways. As I mentioned, asthma is now separate. Okay, so it's now under allergic disorders. Let's look at how we develop this. Okay, is our respiratory system sterile? Is it sterile? Correct, it's not sterile. Because is the air we're breathing sterile? No, who knows what's in the air, right? No problem though. Yes, sir.
But isn't it a surfactant helps with with the air?
Yes, of course. Surfactant keeps your lungs, it's like a detergent, right? Keeps your lungs from collapsing. It's whenever it's produced by your body, of course, it's from a gland, correct? If it's from a gland, then that means it's sterile. However, the things coming into the respiratory tract makes it unsterile. Does that make sense? Yeah, so the respiratory tract system is not, it's not sterile. You agree with that? Okay. Listen to this. Does that sound sterile? It's not sterile, right? Okay. So we breathe in so much debris day in, day out, depending also on where you live or what your industry is, what your livelihood is, or like, let's say your lifestyle. You smoke pot, you smoke cigarettes, okay, or whatever else you smoke, or you work with asbestos, or you work in a coal mine, for instance, or you work outside all the time. You're in the desert, for instance. Okay, so we expose our respiratory system to so much debris, but no problem. There are two enzymes, powerful enzymes that we have innately. So we have cells that produce protease. What is protease? It's a powerful enzyme that can destroy anything. So most, poop you or other debris that you breathe in, from bird poop or dog poop, you smell. I mean, you breathe in while you're walking outside. It's fine. We have mucus, right, which trap it. So we have mucus producing cells, and all those debris get stuck there. And then, besides expectorating it out, we have protease, which will destroy them. So protease is produced, and then they have one job, which is to destroy stuff. Okay, so when you have protease, it'll be destroyed. Don't worry, because you also have something called another enzyme called alpha-1 antitrypsin, which is now going to stop the action of protease. That's the negative feedback. Okay, so again, the stimulus is, of course, you inhale something dirty. Feedback is to destroy that dirty stuff, right? Which is now the production of protease. Then protease will destroy that debris. Then we also need something to stop protease, which is alpha-1 antitrypsin. So if there's a good balance there, you have no respiratory problems. Most common cause of COPD is smoking, because it's like this. So you and me who don't smoke, who don't live with someone who smokes, meaning we're not first hand or second hand or third hand smokers, right? Where our protease and alpha-1 antitrypsin levels are balanced. The problem with smokers is, are they exposing themselves too much to pollutants? Yes, constantly. Okay. So whether they're at home, at work, The only time they stop is when they sleep, right? Can you smoke while sleeping? No, you have to, you're unconscious. You can't smoke. The problem with that is, so the longer you've been smoking, what happens to number one, the size and number of your mucus producing cells?
Size and number of it increase
It actually increase, right? Because you need more mucus. Yeah, you're exposing yourselves to too much nicotine and other toxins. Yeah. So they get bigger. They're more hyperactive. That's why you see smokers, they cough and then they spit a lot, right? Yeah, because they have a lot of phlegm, a lot of mucus. The mucus is also very thick. Also, their protease is also increased. Okay, so they have a higher protease. It's fine, they have alpha-1 antitrypsin. The problem is when they sleep, because the protease continues to be produced because it's a habit. Okay, so the body learns, we need more protease because there's so much smoke coming in. So even when they sleep, there is still protease. So what will protease do when there's no nicotine or other toxins coming in? They'll destroy something else. They'll destroy your airway now. So they'll destroy the villi, they'll destroy the epithelial cells lining your respiratory tract, and then eventually they'll destroy your alveoli. Okay? So now you're auto destroying your lung structures, okay? Because you're smoking. In a few less than 10% of people with COPD never smoked, never had first-hand, second, or third-hand smoking. But they develop COPD. For those people, they have a genetic deficiency. They don't have alpha-1 antitrypsin. Or I should say, they don't have enough. So therefore, yes, their protease is normal, but they don't have enough alpha-1 antitrypsin, which will suppress protease. So because of that genetic abnormality, now they develop COPD, but these are very small population. So most of our COPD patients are smokers. And even when they have COPD, they still smoke. Okay, so this is what I mentioned earlier, the proteinases. So if you're interested, read the whole paragraph. Okay, and then that will explain what we just concluded. And here's the alpha-1 antitrypsin. And again, a small number of people have a deficiency of this enzyme. The first type is called chronic bronchitis. This is involving the larger airways, okay, the upper larger airways from the main stem bronchus, from your trachea to the main stem bronchus and to the left and right main stem bronchi. So what happens here, I already described what happens because the smoker constantly exposes themselves to nicotine and other substances. So what happens to the size and number of your mucus producing cells? Okay, they increase in number, they increase in size, therefore they make more mucus. Okay. My father smoked since he was 7 years old, up until he died at 81. Okay, he had multiple strokes, and it's not a fun life. Okay, watching him expectorate, having to expectorate nonstop, okay, large amount, and it gets very hard for him to cough it up, okay, no matter how much nebulizers, how much water you give them. Plus, of course, because of his smoking history, now he has heart disease. Okay, so in fact, he had a heart attack, a stroke, multiple episodes. So this is what happens to the chronic bronchitis airway. So on the left, that's your normal diameter of the airway. So the walls are thin, correct? So the muscles are strong. Okay, they can react, they can constrict, they can dilate as needed. Look at the lumen or the size of a patient with chronic bronchitis. The size overall is the same. The lumen or the opening narrowed because of chronic inflammation. The airway is a smooth muscle. It's a muscle. So therefore, Does it have blood vessels? Yes. So when there is chronic airway inflammation, what happens to the size of those blood vessels during an inflammation? If they're inflamed, they dilate, right? They dilate, increase in size, so therefore it thickens the wall because the blood vessels, instead of very skinny like here on the left side, you can't see the blood vessels. Okay, the capillaries that supply it are so small and they're not dilated. Here, once you dilate each of those capillaries because of chronic inflammation, it thickens the wall, but in so doing causes a narrowing of the opening of the airway. So therefore, very difficult to get air in, even more difficult to get air out. Okay, so it's difficult to breathe in, even more difficult breathing out. And this is forever. Okay, so we now need medications in order to dilate these things so that they can receive adequate oxygenation. The other problem involves now the lower airways all the way to the alveoli. So same cause we described earlier, from the protease to, from smoking, the protease, alpha-1 antitrypsin, same thing. But this time, this now involves the lower airways, the lower air sacs. So on the left side are normal air sacs. Okay, so they're supposed to look like that, individual grapes, and not shown in this illustration is there are capillaries around it, right? So each one of those grapes are surrounded by a capillary network, a venous and an arterial capillary, making gas exchange possible. Okay, so now after remember protease earlier? Okay, so after protease does its damage, now the walls are no longer individual. So instead of individual air sacs, they now become one big blob. Okay, the walls of the alveoli were now destroyed and they become one big flabby structure. So instead of these small air sacs, which can recoil, okay, they can squeeze air out. They can also inflate to accommodate air in during inhalation, and then squeeze air out during exhalation. They can't do that anymore if they're one big blob because now they're weak, and those walls no longer permit gas exchange. Okay, so think of it as a lot of dead space because the air, once you breathe, think of it as, let's say, who snorkels here? How long is a snorkel? About 2 feet, right? Yeah, 1.5 to 2 feet long. Imagine breathing through a really long snorkel, a 6 foot long snorkel. When you breathe through a 6 foot long snorkel, yes, during your first breath, you'll take in oxygen, correct? But when you exhale, what's in the snorkel? CO2. So the next time you breathe in, what are you breathing in? CO2 and maybe some oxygen. Okay. So with each breath, what's happening to these CO2 levels? It's increasing each time. Same exact story here. So that big blob there is now a lot of dead space. Okay, so useless dead space, meaning it's full of CO2. That's why we call them CO2 retainers. Okay, because they can't get rid of that. So we have so much residual volume, meaning so much air from the last breath, you can't get any new breath in because of that dead space, because it can't be pushed out. Okay, because those used to be normal alveoli are no longer strong enough to push the CO2 out. So you got a lot of residual volume from each last breath. Okay, and then you take in very little new air. Okay? And then of course, what will happen there? There's mucus there, right? So remember, our respiratory tract is not sterile. So
Debris.
right, so debris, bacteria, or other organisms grow, and then you get pneumonia, you easily get the flu, you get hospitalized repeatedly every year. Okay, and then good thing though, you'll get to know nurses, you'll get to know doctors. Hey, I'm back. Hey, all right. So, but you're missing work, you're missing school, you're missing holidays, you're missing birthdays. Okay, but you can always have the birthday in the hospital, right? They only allow 2 visitors at a time though, so just go in, take your selfies, and then that's it. We can't have a party in the hospital room. There's no space. So any question on bronchitis and emphysema? Okay, both are COPD disorders. Most patients who smoke though have both. So they have chronic bronchitis and emphysema at the same time. So jackpot. So I already mentioned, they have recurrent infections as a result. Okay, they cannot expectorate all that mucus. There's a lot of residual air. So they have increased CO2 levels as a result. Now, this will change the physiology because now their CO2 levels are so high. In the normal person like you and me, what makes you yawn, by the way? Low or high of something? You're high in CO2. Okay, because let's say you're listening to me, let's say you listen to my lecture at home. Okay. All right. Okay. So your respiratory rate drops. Okay, that's what happens first. Something really boring. Respiratory rate drops, and then once respiratory rate drops, what happens to CO2 levels? They rise. So what will your body do? Can you kill yourselves by holding your breath? No. So the stimulus is the high CO2 level. So because your CO2 levels reach a higher than normal level, your brainstem takes over, starting with it increases your respiratory rate, starting with a yawn. So you start with a yawn. And then your oxygen levels rise, right? Oxygen levels rise. The stimulus was negative feedback, then you're alert again. Okay, and then until the next few minutes, there you go. Right, and the CO2 levels rise. Okay, now these people always have high CO2. So now, will their brainstem still react to this? It's always high. Not anymore. No, they become desensitized. Okay, so the brainstem no longer responds. It's high CO2. It's always high. Okay, it's always high. So what are they gonna respond to now? The opposite. They will now respond to low oxygen levels. So this is the reason why. How much oxygen can you give a COPD patient? Not too much, because what is their stimulus for breathing? Low CO2 levels. They no longer respond to high CO2 because it's always high. So they become, the brainstem again becomes desensitized. Okay, it will not respond to high CO2 levels. So the only stimulus for breathing is low oxygen level. So therefore, if you give them a lot of oxygen, why would the brainstem still need to breathe? Make sense? So you are suppressing the respiratory drive. The brainstem won't need oxygen is already high because you flooded the patient with oxygen. So patient will stop breathing. They'll go into respiratory rest and die. The high pressure here, higher blood pressure in the pulmonary artery caused by a combination of both, like here, for instance, or in emphysema here, this causes pulmonary hypertension. Now, which side of the heart pumps blood to the pulmonary arteries? The right side. So what type of heart failure will result? right-sided. If the patient's right-sided heart failure is caused by pulmonary hypertension, it's called cor pulmonale. Okay, this is right-sided heart failure. It looks the same if you take an X-ray, whether it's caused by a valve problem, a dysrhythmia, coronary artery disease versus pulmonary hypertension from COPD. That X-ray will look the same. However, the treatment will slightly be different. You agree? Yeah, because do you need to treat CAD and everything here in if it's pulmonary hypertension? No. Okay, so that's why we need to distinguish, because that way we can treat the patient appropriately. Okay, because yes, we'll treat them for heart failure, same thing as with any other right-sided heart failure, but we add something else. Okay, we add some more medicines to treat the pulmonary hypertension. Risk factors, again, it's tobacco, smoking, other pollutants. It's not just smoking, but number one, of course, is smoking. We have, by the way, there's no distinction whether you smoke tobacco or weed. It's the same. They cause COPD. Or hookah. There's really no difference. Huh? We don't have data yet, but I'm willing to put $100 in it and it'll have the same. Okay. So here, pipe, cigars, doesn't matter whether it's first hand, second hand, or third hand smoke. You know what third hand smoke is, right?
No.
No, the smoky smell from the hands or the clothes on the couch, in the car. Yeah, that's third hand smoking. Yeah. Uh-huh. So when you live with somebody who smokes, you're a smoker too. That's not a neighbor, that's a roommate. If you can smell it like that. Okay? That's your roommate. Okay, here's a list. So again, exposure, first, second hand, or third hand smoking, age, occupational exposure. Again, you're a coal miner or whatever industry you're in, you're exposed to so many pollutants, small aerosolized particles. So here, e-cigarettes, that's the vaping, right? So we have e-pens, e-pipes, hookahs, cigars. Right. And again, a small percentage, see, 1 in every 1,500 have alpha-1 antitrypsin deficiency. But again, very small, yeah? 1 in 1,500. So here's the protease, okay, I was mentioning earlier. Manifestations. Because this is a chronic condition forever, you do get cured if you get a lung transplant. But yeah, just like heart failure, this is chronic. So will the patient ever be normal? No. So let's just call these set of signs and symptoms as expected. Okay, these are expected manifestations. What are they? Now, the problem with this here is there's no, over the next few paragraphs, there is no table or chart. The author just explained what are chronic and what are signs of an exacerbation or flare-up. Okay, so you have to read, let's say, for example, if you read this paragraph, chronic cough and sputum production. Since this lasts for years, is this chronic or acute? This is chronic, okay, meaning expected. So what is expected or chronic? The cough, the sputum production, and the dyspnea. However, they do worsen over time. Now, if the patient has any change from their usual chronic symptoms, are those acute now? Yes. So signs of an exacerbation or a flare-up, therefore, are anything acute. For instance, if the sputum changes from either clear and white, which is their usual, now it's green, it's yellow, it's brown, okay, orange. Okay, nice, like bubble tea colors. Are those reportable now? Yes, those are acute symptoms. They need to report that. Um, the reason for reporting early is so that we avoid hospitalization. We can treat them ahead, from home. The doctor will just simply prescribe steroids. That's usually the case, or uh, uh, maybe if appropriate, prescribe oral antibiotics. Okay, so that we avoid hospitalization, because hospitalization again, it disrupts your life. Yeah, you have to stop work, can't take the kids to school, whatever you need to do. Okay, and then of course it interferes with your daily activities and plus your quality of life, which is very important. So maybe the respiratory rate daily would be around 22, 24. They can live with that. However, when the respiratory rate is now 28, 30, 32 or higher, can you survive like that? Let's try breathing 32 per minute. So that means that is 16, that is 8 breaths per 15 seconds, yeah? Okay, let's see. Go. 4, 5, 6, 7, 8. That's eight in 15 seconds. Can we keep that up? How are you gonna eat? Let's see. I can't. You can't swallow in how long does it take to swallow? Like 3 seconds, yeah? Yeah. No, just swallowing. Takes a long time to swallow. Yeah. And breathe at the same time? No. Okay. So what happens now to their nutrition? Yeah, they lose weight, okay, can't eat, can't breathe, can't eat, yeah?
Because are they always tired too?
What do you think? Because they're malnourished, plus there's expending too much muscles. Because normally, are we using any muscles to breathe? No. Our diaphragm does the work. Yeah, we just relax. We talk, we gossip. That's all we worry about. Breathing is the least of our concern. Yeah, breathing is automatic. Okay? We'll talk about acute and respiratory failure next semester. Okay, that's a separate chapter. Changes over time due to high CO2 levels again, meaning if your CO2 levels are high, that means what are your oxygen levels? Low. Okay. So therefore, chronic hypoxemia can lead to changes in your body structure. One of those changes is a barrel chest. So that's chronic lung inflation. Remember the picture of the emphysema earlier? Okay, so if your alveoli look like that times 100 million of them, so your chest will become round. Another is your fingers. Okay, so the digits, your fingers and toes will start clubbing. Again, because of chronic hypoxemia, chronic low oxygen flow to your fingers, especially the fingertips. So that's what you look like now. And this is now the diameter. Now, it may look, oh, this doesn't look so bad. Actually, it is. Remember, the heart is at the center. If you change the shape of the chest, it actually compromises not just the heart, but the lung at the same time, because now you have lesser, see, the surface area for lung expansion decreases. Okay, so this is your spine. This is your sternum. Okay. So if you change it like this, now there's less. See, here we have really wide, you have a very wide surface for lung expansion. Not so with this one. So you have less, plus remember there's residual volume, okay, you have to deal with. So overall, you're short on oxygenation. Okay, so they therefore require oxygen therapy at home. Just like heart failure, COPD has, remember we discussed class 1, class 2, class 3, class 4 heart failure, NYHA. So here we have a gold classification in COPD. So here's our class. It's still the same. Class 1, we have gold 1, 2, 3, 4 right here. Okay. So you have grade 1, grade 2, grade 3, grade 4. But this time, our basis is no longer the patient's symptoms with, uh, you know, ordinary activities. This one is now based on FEV1. So what is FEV1? That stands for forced expiratory volume in 1 second. Now, how do we measure that? We measure that with a machine. So your doctor will ask you to come to his office and using a spirometry. Spirometry is a machine. This is not the, incentive spirometer you give to post-op patients. That's not it. That's not a spirometer. And that's a spirometer. This one is spirometry. It's a big machine with a few hoses. Okay, so what happened is the patient will be asked to perform several maneuvers into the hose. They will be blowing repeatedly into that hose at time sequences. With, of course, this will be managed by either the doctor or their medical assistant, and they will be measuring the following: FEV1. So this is the pressure exerted by the lungs in 1 second, meaning this will determine how strong are your lungs. Well, technically, it's the diaphragm we're really measuring, but this is in mLs. Okay, so how many mLs of air can you forcefully blow in 1 second? So that's the basis of the strength, basically, of your lungs. So if your FEV1 is now less than 70, less than 80, less than 50, less than 40, that will determine your grade. Okay, whether you're in gold 1, 2, 3, or 4. So just like in heart failure, grade 1, mild. Okay, so can these guys work, go to school? Yeah, no problem. Grade 2, maybe, but they will have symptoms. Okay, so they probably require oxygen therapy now. So these are the guys that you see, in church having oxygen, yeah. And then we have grade 3. Of course, these people can these people really walk? No, they're probably, yeah, yeah, they're probably,
Their oxygen almost.
yeah, in the back, in the back. If you go to church, they're in the back of the church, trying to not catch any attention, okay, to themselves. And then grade 4, these are either in hospice or in, you know, uh, yeah, they're in homebound, they're in bed. Complications, I mentioned the heart failure. Yeah, what do you call that again? Right side heart failure? Cor pulmonale. Okay. Others are, of course, on top of the cor pulmonale. These are the more dangerous complications: pneumonia, repeated bouts. You get pneumonia. They'll easily catch the flu. So these people have to be vaccinated regularly, flu and pneumonia vaccines, and RSV as well. Chronic atelectasis. You know what atelectasis is, right?
Lung collapse.
Okay, maybe you can't picture it. Let me show you what atelectasis looks like. Now, we won't have a human here, but we can have a chicken or a rabbit. Okay. So we call this therapy lung recruitment.
You're recording again. This is a different.
I think this one is from a rabbit. This is a rabbit lung. So atelectasis, see those dark areas right here? So these parts of the lung, these lobes are inflated. Okay, these are normal. But you see how these areas look wrinkly
Yeah.
and like it caved in? Okay, so those are collapsed areas. Okay, and watch how recruitment happens. When we say recruitment, we add positive pressure into those areas, and they will reinflate. Okay, watch. It's just very short.
Angle and on short sweep, and we're going to go to 15 of PEEP now.
So now we add PEEP. Look, pop, 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 pop. They pop, right? You see, they pop open. Okay, so that's what we call lung recruitment. See, and then one more. Come on. There. One last one. There we go. Okay, so we now fully inflated the lung. Okay, so that's the same therapy we will do. Of course, this is miniaturized. This is a rabbit, I think. So of course, it won't work like that in the human lung. Okay, so when we recruit them, it'll take a long time to recruit it. Okay, so these people will be advised to be on BiPAP, CPAP, and that's what it does. Okay, they recruit, they recruit lung tissue. Again, positive airway pressure. You don't have to be ventilated. You don't have to be on a ventilator, but regular CPAP use, yeah, or BiPAP use. Okay, that will help. Plus with the breathing exercises and bronchodilators. Okay. Okay. Medical management, of course, we reduce your risk. Go stop smoking. It's never too late to stop smoking. Okay, even how long you've smoked, there's no such thing as, oh, it's too late. No, it's never too late. Stop smoking. Okay, that will still make a difference. Yeah, it won't save your life probably, but it will improve quality of life. Uh, keep in mind though, smoking doesn't just cause COPD. Smoking has been linked to cancer as well. So in this chapter, we're just talking about COPD, okay? But smoking will kill you in other ways. So of course, we ask them to stop smoking, yeah? How they do that, we have many forms, okay? We can have gum, okay? Or there's always cold turkey, yeah? Okay, oxygen therapy. So we said earlier, how much oxygen can we give these patients? What did you learn in fundamentals? Around 2, right? 2, maybe 3 liters. Read this though. That's fine, right? Okay, but in okay. Because these patients have long chronic hypoxemia, yeah, or hypoxia. Read this one right here. With long standing, go ahead. Just one person, Isabella, thank you for volunteering. With long standing
hypoxia, as seen in patients with COPD, as well as in patients with chronic heart failure, fatigue, drowsiness, apathy, inattentiveness, and delayed reaction time may occur. The need for oxygen is assessed by arterial blood gas analysis, pulse oximetry, and clinical evaluation.
Okay. What this means is even if, yeah, as a general rule, we don't give more than 2 liters of oxygen to a COPD patient, right? Okay. But during an exacerbation, though, when they're having a flare up, what is the basis for oxygen therapy? The blood gas analysis, the pulse extremity, and the doctor's clinical evaluation. Meaning, can we give more than 2 liters? Yes, if they need it, yes, we do give more than 2 liters. Are we clear? Okay. So, meaning in practice, especially when these patients are intubated, we give more than 2 liters. Does that make sense? Meaning once they're on a ventilator, that's way more than 2 liters already. Okay. And that even, in fact, that improves the patient. Of course, we don't put them on that forever. As they get better, our goal is always to wean them off of the oxygen. Because remember, oxygen, is it also toxic? Yes. Oxygen toxicity is dangerous as well. So here, we should not over administer oxygen. Here, increased amounts of oxygen may produce toxic effects and can be lethal. That's oxygen toxicity. So if you give a COPD patient high fraction of inspired oxygen, meaning high FiO2 for longer than 24 hours, this can kill the patient. Right? But if they need it, of course, we give it just as long as there's a limit. So as a general rule, here we go. Using the lowest amount of oxygen needed to maintain an acceptable PaO2. Now, as far as oxygen saturation, for COPD patients, 88 and 92%, that range is acceptable. 88 to 92%. So if we hit that, are we good? Yes, because anyway, are these patients ever going to have normal oxygen levels? No, they're used to that anyway. Okay, they're used to high CO2, low oxygen. So are we happy with 88 and 92? Yes, that's good enough. But of course, in practice, that's just from the textbook. In practice, we're happy around 90. Okay, so 90%, good. Because 88 always sounds bad, yeah? That's the 90. We want to see at least 9 there, okay? But the textbook says 88 and 92. But in practice, we at least should have 90. I won't review this. This is from fundamentals. Okay, so we have different oxygen delivery systems. We have cannula, we have the Venturi mask, we have the simple mask, we have the partial rebreather, we have the non-rebreather. Here's the Venturi. We have a face mask. We have tracheostomy collars. TPs, we'll discuss this later when we get to artificial airways. That's next semester. Let's go to pharmacologic treatment now. Six 14. Okay, so here again, our threshold for oxygen therapy is if the patient's oxygen saturation is at or below 88%. So meaning once we hit 89, is that good now? Yes. Okay. I had a doctor before. Well, Shah is a very common Indian name anyway, so I'll just say his name, okay? So Dr. Shah was very strict. He was very stingy about oxygen. So usually, nurses give oxygen to patients, and then get the order later. With Dr. Shah, you should never do that because whenever you give oxygen to his patients without his order, he would write you up. A lot of us got into trouble because we were so used to most doctors, patient's oxygen's low. Am I going to wait for a doctor to return my page and then watch my patient? I'm sorry, I didn't have orders yet. And then the patient, of course, I give oxygen, right? This doctor is different. He says, no. His reasoning is oxygen is free. Why should you give the patient oxygen? There's oxygen in room air. Says there's 21% oxygen in room air, So anyway, so we've been tired of arguing with them. But my advice is get to know the doctor because I don't know how many Dr. Shahs, you know what I mean, right? Yeah, how many of him are out there? So unless you know the doctor, I wouldn't, risk it. Okay, let's go to drugs now. There are two sets here. We have short-acting bronchodilating agents, and then we have long-acting bronchodilating agents, SABAs and LABAs. They're not listed here because they're under asthma. Why? What did I say earlier? Okay, medications for asthma and COPD are the same. Okay, so let's go to asthma. Right here, asthma. Just under medical management. There we go. So we have a table. 20-5. So the short-acting are beta-2 adrenergic agonists. So beta-2 meaning arteries that supply what? What do we have two of? 2 lungs, 2 kidneys, okay? So those arteries are affected by these drugs. You follow? Okay. So those arteries will be constricted or dilated. Beta-2 adrenergic agonist. When we say adrenergic, what does that refer to? Epinephrine, okay? Adrenal hormones. So what do epinephrine and norepinephrine do? They cause vasoconstriction. Now, how does vasoconstriction lead to bronchodilation? Remember the picture of the chronic bronchitis earlier? Can you picture that? Now, the ones on the left was wide, the one on the right was very narrow. Okay, so what did I say earlier? Why was it very narrow on the right side? The capillaries, the blood vessels were very dilated. So now if you give them vasoconstrictors, because these are beta-2 adrenergic agonists, they're not antagonists, they're agonists. So therefore, they cause vasoconstriction, same exact effects as your sympathetic hormones. Okay, same exact effect as epinephrine. So therefore, when you cause vasoconstriction, this will cause bronchodilation. Does that make sense now? Because now the walls will thin because you constricted the blood vessels. Make sense? Okay. Let's go to side effects. Because this is like epinephrine, what will be the side effect? Tachycardia, hypertension. Okay. Here, muscle tremor. Patient will have palpitations, shaking, okay, tremors. These are side effects of any sympathomimetic agent. All right. Okay. So examples are albuterol, levalbuterol, metoprolol, but the most common are the first two, albuterol and levalbuterol. We have anticholinergic agents. So if a patient already has tachycardia for some reason, let's say they have a cardiac issue, contraindicated, yeah, you can't give a beta-2 adrenergic agonist like albuterol because what's the side effect? Tachycardia. Patient's already tachycardic to begin with. Can't give it. Now you can give an anticholinergic. Ipratropium, because you can have combination, actually you can have albuterol. Some drugs like Duoneb are ipratropium and albuterol. So you can separate them though. So instead of giving both, you can just give ipratropium, an anticholinergic, same effect, but different action. This one will inhibit muscarinic cholinergic receptors. This one will do the opposite. So this will have parasympathetic effects. Okay. Then we've got steroids. Steroids here can be local or systemic. When we say local steroids, that means these are the inhaled ones. So steroids can be a MDI, meaning wet spray, or it can be a dry powder. All right. But whether it's wet or dry, if you inhale it, it's usually local bronchodilation. The systemic ones are either IV or PO. Methylprednisolone is IV. So the highest dose you can give here is 125, lowest is 20/40. Or doctor may order something in between 80. But usually we give, let's say patients come in with a severe asthma attack, right? Or severe COPD, and respiratory failure. We give 125 of this one time, and then we'll give them 40 every 8 hours. So it works like magic. Patients suddenly get better. What's the side effect? It's a steroid, so hyperglycemia. Hyperglycemia, of course, is manifested in high polyphagia, right? So patients' appetite will increase, especially in women. You guys get bloated, yeah? Yeah, bloated, and especially in your legs. Yeah. Look like you're baking bread. There. Then we've got the inhaled corticosteroids. So we have many. Most common are fluticasone, budesonide. Forget the brand names. You should only be familiar with generics. As with any other steroid, especially if it's local, what are you concerned about? Thrush. Okay, so candida, fungal infection. So what do we do to prevent that? Okay, oral care. So at least rinse, or better even to brush your teeth. Brush the teeth. Now let's go to LABAs. LABAs are usually inhaled, so either wet, meaning meter dose inhalers, or dry powder. These are maintenance. Okay, so the SABAs they use for rescue, right? So acute symptoms, they use the SABA. For long-term maintenance, they take these with or without symptoms, they take them every single day for the rest of their lives. Right? So this will prevent an attack. So here's your teaching. Reinforce to the patient that these medications should not be used to treat acute symptoms. Please disregard the asthma part because remember, this is the asthma section. So of course it will say asthma, but this is used for COPD. All All right, phosphodiesterase inhibitors. These are theophylline. Theophylline is a very old bronchodilator. This is probably over a century old now. I remember in Florida, there was just one doctor who who kept prescribing theophylline. No other doctor prescribed it. Too old. His daughter is already a consultant as well. So imagine, how long does it take for you to become a consultant? Let's say you started med school at 18, okay, or that's pre-med. Let's say you finished that in, let's say 22, 21, 22, 4 years med school, plus there's the residency. So that's around 8, 10 years, yeah, before. And I don't think she started at 20. Okay? And then her dad was already, so too old. I think he's finally retired now. Because I usually see him at Walmart in the garden section. We had the same hobby, like plants. I see him there. He bought way more plants than I did. Couldn't afford it on my nurse's salary. We have combination here. We have a steroid and a LABA. Okay. So a long-acting bronchodilator combined with a steroid makes for a great combination. Okay. So 2 drugs in one, 2 long-actings. Okay. 1 steroid, 1 bronchodilator. Here are more combinations. So just for when you study these, stay with the last column, the nursing consideration, your responsibilities, because that's what the questions will be on. What do you teach the patient? What do you do? There's a once daily leukotriene modifier. The only one of its kind, Montelukast. There's no other drug like it. So this one targets only leukotriene. They discovered that leukotriene is a cytokine responsible for the symptoms you see in asthma and COPD, meaning the bronchoconstriction is caused by this thing, this particular antihistamine. So they stop that, then no asthma or COPD attack. Only comes in tablets, 5 and 10 milligrams. The danger side effects here is suicidal ideation, both in children and adults. The others are not really common, so we can skip those. Plus, they sound very expensive. Okay, when we talk about interleukins, very expensive. So just the ones I mentioned are the most common. Common people like you and me can, our insurance covers those drugs. All right, that's it for exacerbations. Peak flow. Peak flow monitoring is prescribed both to asthma and COPD patients. What is a peak flow meter? There's a picture here. Okay. This one though is a very old peak flow meter. We have smaller devices now, which are easier to carry and more discreet. Fits in your purse. This thing does not fit in your purse, does it?
No.
Yeah. It's like a big smoke pipe. Yeah. Okay. So the purpose of the peak flow is to assess your cough, because usually the first symptom of an attack, whether it's asthma or COPD, is a cough. Patient starts coughing more than usual. They need to grab their peak flow to see. The peak flow, by the way, is established. Do you know what I'm talking about? Do you know what a peak flow meter is?
matter how much, and depending on how much, it depends, they'll send it to the hospital.
Okay, very good. So you know what it is. Anyway, it's a device, okay? It won't rescue anybody. This is not gonna do you any good. This is just it's a diagnostic tool, okay? So you establish your peak flow on a good day, meaning you have no symptoms. Let's establish your peak flow. We give you a peak flow, you establish it. You blow 3, 5 times to it, record the highest number. That is your peak flow. When you have symptoms, you grab your peak flow, blow into it, measure your peak flow. If your peak flow is below your baseline peak flow, you're having an asthma or COPD flare-up. If your peak flow is at or even higher than your baseline, it is not an asthma or COPD attack. Does that make sense? What is it? I don't know. Maybe it's an infection of some sort, but it's not your asthma. Does that make sense? Okay, so what is the purpose of a peak flow? It's a diagnostic tool to determine whether or not you're having an exacerbation or a flare-up. A last topic for COPD is the use of the inhalers. Majority of the patients who get readmissions is because they did not comply, they were not compliant with their medications. Some of them will say, oh, I use my medication regularly. The problem is they're not using it correctly. Okay. Now I have 2 videos that will help explain this. I don't have to. 2 videos explain the steps to the T. Just type in meter dose inhaler. Demonstration. And I want you to watch this check. Okay, how to use an MDI. This blonde. Okay. This one. See, yeah.
Yes.
Okay, so title is how to use an MDI. It's step by step. Okay, if you compare it to the textbook, step by step, it's exactly bullet by bullet. Okay, so it's perfect demo. Now for the spacer, just change the search to dry powder inhaler. Same company who made that previous video, but a different model. This one. Oh. So a different chick. This time, how to use a discus. Okay, so that's a dry powder inhaler. Now there's a third one. Oh, there it came out here. So this one here, discus, and this one. Okay, but now we have a because this one is for people who have good dexterity. But let's say it's a very small child or a really old person, or maybe they have, cognitive or developmental challenges. There should be a spacer. A spacer buys them time. The video would be this one, this chick. Okay, so this one is with a spacer. Okay, so you simply attach the
Remove the cap from the spacer.
so you attach the spacer to the meter dose inhaler and watch the rest of the video. So the medication circulates inside that chamber. Okay, so the patient doesn't have to be in a hurry to inhale it, so they can take their time. Just press on the canister, and then they can take their sweet time inhaling, and then they get so much of the medication because the medication again circulates inside there. Okay, unlike without the spacer, when you do this, you miss the timing. The medication's gone. It's in your teeth. It's in your tongue. It should be in your airway. So the spacer makes that possible.
That a lot for kids, like for.
Yeah, and again, small children or very old people, or anyone again with difficulty. I probably would use this. Okay, if I never needed an inhaler. Okay, that's it. Let's take a break. Come back at 3 o'clock.